Good day. Today's topic is on bone disorders. The first one being osteogenesis imperfecta. So most of the bone disorders that we're going to see here is going to be affected by a gene. So it is going to be a genetic disorder. So osteogenesis imperfecta is also known as brittle bone disease, which is a heritable disease, and it is caused due to the impairment of collagen maturation or formation of collagen, and the mutations are in COL1A1 gene in chromosome 17 and COL1A2 gene on chromosome 7. See, because collagen forms the major portion of the bone, dentin, sclera, ligaments and skin, all of these structures are going to be affected in osteogenesis imperfecta. There are several different forms from type 1 to type 4, and depending on the severity they are divided. The clinical features are the children are stillborn or they die shortly after birth because of the bone deformity that is seen, which is not treatable. They are both autosomal dominant and recessive, meaning they can be heritable from either of the parents, that is from the mother as well as the father. And there is increased bone fragility, so they are prone to fracture. Sclera is blue, like I said, because collagen forms the sclera too. The sclera will also be affected. Teeth are affected because it forms the dentin. Collagen forms the dentin. Hypoacusis, there is hearing loss. There is long bone defects, spine deformities, joint hyperextensibility, dental alterations. There can be both clinical as well as radiographic changes. On the right, we can see that there is going to be brownish tinge in the dentin that is seen in the teeth, and in the radiographic changes we can see that there is increased pulpal space that is seen, and both dentitions, that is primary and the permanent dentition, show blue to brown translucency of the dentin. So the radiographic features are osteopenia, obviously because it's a brittle bone disease, there is less density of bone, bowing of the bone, angulation, multiple fractures, and Vermean bones. They are bones that are formed in between the sutures, specifically the skull sutures. They are seen also in cleidocranial dysplasia, but can occur in osteogenesis imperfecta too. Radiographic features, they reveal premature pulpal obliteration, and shell teeth can be seen. Class 3 malocclusion caused by maxillary hypoplasia. Not that the mandible is protrusive, but because of the hypoplastic maxilla, there is a class 3 protrusion. On rare occasions, multifocal radiolucencies, mixed radiolucencies, or radiopacities similar to that of florid cementosseous dysplasia can be seen. We'll get to what cementosseous dysplasia is. So this is how, if the patient survives, if the patient is of a milder form of osteogenesis imperfecta and they survive to see adulthood, the bones will be deformed and they will have to take the help of a wheelchair to transport or to move from places. Even though they do move to places, initially there is going to be fractures that are seen, and kyphosis or scoliosis can present at the initial stages of life for these patients. So the first picture shows Vermean bones, that is bones that are seen in the sutural lines, specifically the skull bones. And the second picture showing femur being deformed. There is the angulation of the bones, long bones. And the third picture showing there is maxillary hypoplasia seen. So as mentioned earlier, there are 4 types. The type 1 is the most common and the mildest form, which has bone fragility. The features can be very similar. The only differentiating feature is going to be the sclera that is going to be present throughout the lifespan or during the childhood alone. Fractures are present at birth about in 10% of the cases. Because it's the mildest form, the fatality is going to be less. The hearing loss occurs before 30. Joints are hypomobile and bruising can occur because of capillary fragility. Dentin is opalescent, and the sclera are blue at all ages and aid in the classification. Because it's a milder form, they tend to live out the childhood and see adulthood. So sclera is going to be seen at all ages and it's blue. It's an autosomal dominant. Osteogenesis type 2 imperfecta type 2 is the most severe form, contradicting to the type 1, which is the mildest form. It occurs at a young, the bone fragility occurs at a very young age, wherein there are frequent fractures because it's a severe form and may occur even during delivery itself. Many patients are stillborn and 90% die before 4 weeks of age. Blue sclera are still present and opalescent teeth are seen. Dominant and recessive autosomal patterns. So type 3 again is a severe form, but it's less severe when compared to type 2 forms. The sclera is not blue here, it's maybe pale blue or grey at birth, and if discoloration is present, it's only present at a very young age and then fades. Ligament laxity is there, hearing loss is common, fractures are present at birth, and there is a low mortality rate in infancy, but then it can present because it is a severe form. The individuals die during childhood, usually from cardiopulmonary complications caused by hyposcoliosis, which means the spine is bent and in the forward as well as in the lateral direction. So because of its bending and the very less space that is available in the rib cage and between the rib cage and the spine, there is going to be cardiopulmonary complications, so they do not live to see adulthood. Some patients have opalescent dentin, but it's not very common. Type 4 is with mild to moderately severe bone fragility. Sclera may be pale blue in childhood, but then it fades later in life. So as the type increases, the blue sclera's presence also fades later into life. Fractures are present at birth. Fractures, the probability of a fracture will decrease after puberty. Some of the patients have opalescent dentin, but some can have normal teeth also. This is an autosomal dominant. So treatment is, there is no cure because it's a genetic disease. Symptomatic improvement alone can be done. Mainstay of treatment is physiotherapy, rehabilitation, and orthopedic surgery. Medical treatment is IV oral bisphosphonates to reverse the bone resorption that is taking place. That is because it's a brittle bone disease, and this treatment is reserved only for moderate or to severely affected patients. Implants can be used, but the quality of bone is going to be deficient. Bone density is there, so another option can be preferred, maybe removable appliance or dentures can be preferred. For malocclusion, orthodontic surgery can be done. Alternatively, osteodestruction may be a consideration when treating patients with osteogenesis imperfecta in the dental aspect. The next disease is cleidocranial dysplasia. There is mutation in RUNX2 gene and chromosome 6 at the chromosome 6, and this is the gene that codes for osteoblastic specific transcription factor. It is an autosomal dominant trait, affects the dentition, skull, and the clavicles. The clavicles more commonly. Patients are of short stature. Face is small when compared to that of the cranium. There is hypoplasia of the maxilla, brachycephalic skull, presence of frontal and parietal bossing, which means the frontal bone is very prominent. The paranasal sinuses are underdeveloped and increased risk of sinusitis, hearing loss and recurrent otitis media, delayed closure of the cranial sutures, and the fontanelles may remain patent, that is open beyond the normal time, which is over about 18 to 24 months they remain open. So the bridge of the nose is broad and depressed, showing hypertelorism. Hypertelorism is the gap between the two eyes, that is when you measure the distance between the pupil of the eye, the distance is going to be greater. There is complete absence or hypoplasia of the clavicles, which allows for extensive mobility of the shoulders. Mandibular symphysis remains open, and there is prolonged retention of primary teeth, and because of the retention of the teeth, many permanent teeth remain unerupted. There has been a case where as many as 63 teeth have been found impacted. Histological findings show decreased resorption in multiple reversal lines, which may account for delayed eruption of the teeth. So as we can see the first image here, you can see the heart is on the opposite side also. There is absence of clavicles on the first image showing the chest X-ray. So this is how this is one characteristic feature Patients can bring their shoulders to the center and they can be joined because there is no clavicle that is present. Later, when you can see in the third image, that is the C image, you can see that the fontanelles have been open, whereas this is a skull of an adult. So the image B, you can see that there is going to be less density of bone that is present. Also in image C and D, you can notice that there are multiple impacted teeth, hypoplasia of the maxilla that is seen. Okay, this image E shows orthodontic treatment for the patient done, below which there are multiple impacted teeth that are seen. And the sutures, they do not close, also seen in E, F and G. The suture or the parietal bones do not close, that the fontanelle that is remained open in these images. Okay, this is an OPG of a patient with cleidocranial dysplasia showing multiple impacted teeth. Treatment is removal of the primary and the supernumerary teeth, that is delayed exfoliation of the teeth. These primary teeth have to be removed and the supernumerary teeth can be removed. You can orthodontically move certain teeth into place if needed, or all of the teeth can be removed. Dentures can be preferred, implants can be preferred for such patients. So you identify these patients below 5 years of age, taking advantage of the combined orthodontic and surgical treatment. Prosthodontic rehabilitation with implants can be done. Next disease is Paget's disease of bone. It was first described as osteitis deformans, and it can be of monostotic or polyostotic forms, which means it can involve a single bone or multiple bones. There is rapid bone resorption and deposition at the same time that occurs in Paget's, and results in reversal lines, numerous reversal lines, which gives a mosaic or jigsaw puzzle appearance histopathologically. The clinical symptoms include pain because there is resorption, also increased bone formation there. Bone formation can result in narrowing or compressing the nerves, so there can be pain. There is deformity in the bones, which may lead to fracture of the affected bone. If it is going to be in the resorptive stage, there can be fractures. The enlarged and deformed bones resemble lion. The other name is leontiasis osseosa, which may compress the surrounding nerves and causes neurological symptoms like hearing loss. The maxilla-mandible ratio is 2:1. It affects more the maxilla than that of the mandible, and most commonly affects bones such as the spine, femur, skull, pelvis, sternum, and the jaws. And in the order of this is in the order of its occurrence. So the jaws is later after the spine, femur, skull, pelvis, and sternum, mostly after if all of these is affected. So if you find a lesion in the jaws, you might go in looking for any other areas where this disease has been affected. If it occurs in weight-bearing bones, it often leads to a bowing deformity, causing a monkey-like stance for the patient or a simian stance. Elderly men over the age of 50 are affected, and there are hypercementosis following the resorption of roots of the teeth, together with a mosaic pattern of new cementum, will give a vital confirmatory evidence of Paget's disease on a radiograph. So this is how it is going to occur. Patient is going to have a lion-like face wherein there is going to be bone resorption and bone deposition in the area. As you can see, the patient is having a broad nasal bridge and a deformed face. So how the alveolar ridge is going to occur is similar to that of Paget's disease. There is another disease called fibrous dysplasia, wherein the maxilla again is affected, and it is another fibro-osseous lesion. But in Paget's disease, the expansion of the ridge is very uniform. But in fibrous dysplasia, there is a specific bulge that is seen in the expansion of bone. Whereas Paget's disease, it grows along the ridge itself. Okay. The etiology of Paget's disease is that, like already mentioned, it's a disease where there is bone formation as well as resorption that takes place simultaneously. So there is inactivation mutations in TNFRSF11B gene that encodes osteoprotein, which is the protein that regulates bone metabolism, that is bone formation, and there is mutation in the sequestome gene P62 that encodes for a scaffold protein for NF-kappa B signaling pathway. So the NF-kappa B signaling pathway, it mediates the differentiation of monocytes and macrophages, that is into osteoclasts, which are responsible to resorb bone. So there is bone formation with the help of osteoprotein and bone resorption with the help of the NF-kappa B signaling pathway. So both take place at the same time. Viruses such as paramyxovirus and respiratory syncytial virus have also been reported to be the initiating or the predisposing for Paget's disease. So this is the histopathological feature characteristic for Paget's disease. You can see the turnover lines, bone turnover with the reversal lines that are seen, forming a mosaic pattern under a microscope. So in skull, large circumscribed areas of radiolucencies, which are osteoporosis circumscripta, are seen, and during the that is radiolucency during the resorptive phase, and during the osteoblastic phase, there is areas of sclerotic bone formation, which is cotton wool appearance that can be seen. Teeth show hypercementosis, and the laminodera becomes less evident. Cortex is thinned out, but it's intact during expansion. Early stages, there are 3 stages. Initially there is bone resorption, then the mixed stage, and then the bone formation. So the trabeculae are elongated and arranged in a linear pattern initially, then they become short trabeculae with random orientations, which are very similar to that of the disease fibrous dysplasia can also be seen. So radiopaque patches like cotton wool can be seen, and scintigraphic appearance characteristic for Paget's disease is the black beard or the Lincoln's beard sign that can be seen from the condyle to condyle, because Paget's disease, when it affects the mandible, it's going to affect the entire mandible, that is both quadrants of the mandible. Okay, the first image on the left is a lateral skull view showing cotton wool appearance, and on the image on the right is of the teeth showing hypercementosis. The one below on the left is the occlusal image of the mandible showing cotton wool appearance again. On the right is the scintigraphic appearance showing the beard sign or the Lincoln beard sign in Paget's disease from condyle to condyle. So diagnosis can be done wherein the blood shows an elevated level of serum alkaline phosphatase and an elevated urinary hydroxyproline level, both of which indicates 2 things, that is the alkaline phosphatase will indicate the osteoblastic activity, and hydroxyproline level will indicate it is a marker for collagen degradation. Paget's disease is usually managed medically using calcitonin or bisphosphonates. Surgery may be required to correct fractures of the long bones. Okay, cement osseous dysplasia is another fibro-osseous lesion. Initially it was named cementoosseous dysplasia, but nowadays it's just osseous dysplasia, and it has 3 other types. Here the bone resorption or the cancellous bone is replaced with a number of fibrous connective tissue instead of bone replacing it, which is very immature, and it's woven. So the 3 forms are periapical cementosseous dysplasia, florid cementosseous dysplasia, and focal cementosseous dysplasia. So it occurs during the 4th and 5th decades of life. Women are more affected than men. The involved teeth are vital with no history of pain or sensitivity. In some patients, the lesions are quite large and can be notable with an expansion of the jaw that can be seen. Low-grade, intermittent, poorly localized pain when simple bone cysts occur in that of cementosseous dysplasia can be seen. Should lesions of focal cementosseous dysplasia become secondly infected, some of the features of osteomyelitis may develop. This can include mucosal ulceration and fistula tracts with suppuration and pain. So the epicenter is located in the periapical areas of the teeth. So for focal or for periapical cementosseous dysplasia. So if it is a focal lesion, it is going to be near the molars, and it's usually for periapical cementosseous dysplasia is the lower anterior teeth, which is a common site. In the mandible, they are located above the inferior alveolar nerve canal. For florid cementosseous dysplasia, the lesions are usually bilateral, can present in both jaws involving all 4 quadrants. The tooth has to be extracted once you find out it's a cementosseous dysplasia, but the lesion can still remain there and develop, and with resorption of the alveolar ridge there can be fistula tracts that can develop showing the lesion coming out. So in most cases, the periphery of the periapical semiosseous dysplasia is well defined. Internally, there may be radiolucency to radioopacity. It can range from, because there has been 3 stages of its development, where it's radiolucent, mixed radiolucency, and then radioopacity. There is a radiolucent rim that forms around the periapical or florid cementosseous dysplasia. It's centered at the apex of the tooth. So if you can see the images on the top, the A is the radiolucent stage of the disease. The tooth is still vital, and when you can see the radioopaque lesion on the right, there is going to be a radiolucent rim that is clearly seen for cementosseous dysplasia. The OPG shows multiple cementosseous dysplasias affecting the 3-6 and 3-7 region, as well as the 4-5 and 4-6 region. So the internal appearance, like already mentioned, is of 3 stages. You can look at the images there. A is the initial stage where there is multiple lesions which are radiolucent. The next stage where there is going to be a mixed radiolucency, radioopacity, and the final stage where there is going to be just radioopacity that is seen. So sometimes these cementosseous dysplasias can develop a simple bone cyst, can be secondarily infected also, and they do not expand the jawbone, but larger lesions can still cause an expansion. A thin intact outer cortex can be visualized, similar to that of which is seen in fibrous dysplasia. The surface of the expanded bone is undulating. So what can be the differential diagnosis for this is cementoblastoma or rarefying. Initially, first thing is rarefying osteitis. You can differentiate it by a filling that is seen, or there can be deep caries that is seen. On the first image, you can see there is rarefying osteitis there, that is bone formation there around the roots of the tooth, but there is going to be a large carious lesion which removed, and there is going to be a large filling that is kept where there is pulpal injury, and there is going to be osteitis that is formed. The next one on the right is cementoblastoma, which encircles the root of the tooth, and the root of the tooth remains behind the cementoblastoma and cannot be seen. The next one is an odontoma, which epicenter is above the roots of, above the crown of the tooth. So with that you can differentiate it. And they resemble dense bone islands. The arrow mark that is showing on the image on the right at the center is going to be idiopathic osteosclerosis. So solitary lesions can resemble also ossifying fibroma, which is seen on the image on the left at the last. Which again has a soft tissue capsule, but there is going to be bone expansion in case of ossifying fibroma. So a Page's disease of bone showing hypercementosis also can be a DD that is for cementosseous dysplasia. Treatment, it does not require much treatment after the removal of the teeth. If it still persists, it can be curated and then removed. The abnormal bone can perforate the mucosa sometimes, particularly when it's located under a denture and there is resorption of the bone and can become secondary infected. Only at that time it can require treatment. If there is going to be an osteomyelitis that is coming secondary from a cementosseous dysplasia, that has to be treated. The complication is secondary infection following biopsy, so it's not very much required. So the next one is fibrous dysplasia, again a fibroosseous lesions where the bone is replaced with fibroosseous tissue. It can be monoosteotic or polyosteotic, very similar to that of Page's disease, which is why the differentiation of both in certain aspects is important, because cotton wool appearance is seen in fibrous dysplasia as well as in Page's disease. But the difference that we saw earlier in Page's disease is it grows just along the bone, and fibrous dysplasia is a large mass that is seen above, not along the bone, but as an expansion that is seen. So fibrous dysplasia, the polyosteotic form usually manifests before the age of 10 and monoosteotic between 5 to 20 years, and it can occur as a part of many syndromes, one being McCune-Albright syndrome, where there is polyosteotic fibrous dysplasia, caffeolate spots on the skin, and endocrine disturbances such as precocious puberty. So they attain puberty at a very early age. And these caveolate spots, as you can see on the right, the image, are seen also in neurofibromatosis, but the borders are different for fibrous dysplasia as well as neurofibromatosis. The next syndrome is the Masobrot syndrome, where fibrous dysplasia can be a part of, along with soft tissue myxomas, and Jaffe-Leschenstein syndrome, where caveolate spots occur along with fibrous dysplasia. So monostatic lesions are asymptomatic, while localized pain may be presenting symptom with fatigue fractures. The polystatic lesions are seen in large weight-bearing bones, and bowing deformities are seen, similar to that of Paget's disease also. Malignant transformation, it ranges from 0.5 to 4%, and it can transform into osteosarcoma, fibrosarcoma, or chondrosarcoma, and the transformation rate is greater for Masobrot syndrome, any fibrous dysplasia which is associated with Masobrot syndrome. It has a classic histological pattern with curvilinear trabeculae, and it resembles Chinese letters. The key feature is the absence of osteoblastic rimming surrounding these characters, which is present in ossifying fibroma. So Paget's disease, fibrous dysplasia, and ossifying fibroma are very similar lesions, where fibrous dysplasia remains the referee between two other lesions, that is Paget's disease and that of ossifying fibroma, where it has common features from Paget's disease and that of ossifying fibroma. The secondary changes such as aneurysmal bone cysts can occur from fibrous dysplasia. So this is the curvilinear Chinese letter pattern histopathological feature, which is characteristically seen in fibrous dysplasia, and there is an absence of osteoblastic rimming around this. As you can see, this eosin area, where there is no rimming of the osteoblasts that are seen around the eosin areas. So the plain radiograph show ground glass or pudy orange or orange peel appearance, which is commonly seen in that of fibrous dysplasia, which can be noted on the IOPA scene, that is the third image. In the proximal femur, in the first image, you can see fractures or a shepherd crook deformity, that is it's deformed, and it pushes the inferior alveolar nerve canal superiorly, which is seen in the IOPA, that is fibrous dysplasia, that is pushing the inferior alveolar nerve canal superiorly. Monostatic forms, usually if it involves the head and neck, the skull base is involved. Bone scans reveal an uptake, but most are useful for identifying the distribution of lesions in the polyostotic form. So computed tomography scanning is the best when it comes to fibrous dysplasia, and it tends to ignore suture lines, meaning if it is going to involve say the parietal bone on the right or the skull base on the for a patient, it is going to involve the occipital, is going to involve the parietal and the temporal bones. So the suture lines do not matter. If it's going to be involve one bone, it's going to spread to other bones too. As you can see, the second image, or the image in the middle, is the occlusal image of the maxilla, wherein which is a common site for fibrous dysplasia to occur. There is expansion of bone that is seen. So bisphosphonate infusion can help to reduce the bone resorption and not replace it with that of fibrous connective tissue. Surgical excision is indicated for severe deformity and for optic nerve compression with vision loss. The disease usually stops after skeletal maturity, so any treatment that is done is waited until skeletal maturity is reached, and then the treatment is done. You can contour the lesion by shaving it down, and radiation is contraindicated because post radiation there can develop sarcomas from fibrous dysplasia. So you have to differentiate it very carefully from that of ossifying fibroma, with the fact that the ossifying fibroma has a radiolucent rim, that is a soft tissue capsule, but whereas fibrous dysplasia, it blends with the normal bone, and the lamina dura is absent from the teeth where it is involved in. So this is how you can differentiate it. So the next one is cherubism. It's a rare non-neoplastic self-limiting fibroosseous disease characterized by painless expansion of the maxilla or the mandible or both. So it's a genetically inherited disorder where SH3BP2 is the gene. Familial cases, non-familial cases have also been reported. So it's received its name from the angel-like appearance of the patient. As you can see on the right, there is a chubby girl that is seen with a chubby appearance, with the upward directed look of the eyes, that is eyes upturned towards heaven. You can see the sclera beneath the iris on the left eye, and this appearance is due to the profound swelling of the maxilla and stretching of the skin over the cheeks and the depressing of the lower eyelids. So occasionally cervical lymphadenopathy is a feature that is associated with cherubism. So there are 4 grades. One is the involvement of just the mandibular molar region and the ascending rami, where the mandible alone is involved along the mentis, and bilateral maxillary tuberosities, if it is also involved along with the mandible, is grade 2. Entire maxilla and mandible except the condyles is grade 3, and involvement of both jaws with the condyles is grade 4. So histopathologically they show foci of extravasated blood, and they reveal osteoclastic character of these giant cells as there is bone loss that is seen. Some cases show eosinophilic cuff deposits around small blood vessels, which is characteristic for cherubism. Radiographically, multilocular radiolucencies, which are present bilaterally with multiple impacted teeth, are seen. As you can see in the images, there are multiple impacted teeth and large radiolucencies that are seen, and it's a primary dentition that you can see for the patient. So it's a disease that occurs early at. Treatment is usually, if it is a milder form, there's no treatment that's required. Surgical procedures can be done after puberty, and roots may resorb, tooth can be displaced, and floating in air, teeth floating in air is one of the common radiographic features for cherubism. Early loss of deciduous teeth and absence or delayed development of the permanent teeth can occur. So again, here radiotherapy is contraindicated. Retardation of jaw growth, osteoradionecrosis can occur because of that, and malignancy can occur. So calcitonin for the bone loss and interferon again to reduce the inflammation can be given as a treatment for cherubism. Ossifying fibroma, it is a fibroosseous lesion again, like I mentioned. Fibrous dysplasia and Paget's disease is another fibroosseous lesion, and the difference of which is necessary for treatment, and the features are going to be very similar to that of Paget's or fibrous dysplasia. So it's a neoplasm composed of fibrous tissue and contains a variable mixture of bony trabeculae or cementum-like spherules or both. It occurs in the 3rd to 4th decades of life, female predilection, and with mandible being most common area. It's different from that of Paget's, being males and elderly males being affected, and the maxilla being the common site. The small lesions have no symptoms, whereas larger lesions have a painless swelling or pain can present with paresthesia. There is mutations in the tumor suppressor gene HRPT2, which have been identified with that of ossifying fibroma, so which is rarely seen, and it can be associated with hyperparathyroidism jaw tumor syndrome, which is characterized by the parathyroid adenoma carcinoma, ossifying fibromas of the jaws, renal cysts, and Wilms tumors. The radiographic features are well defined, and it is unilocular with a soft tissue capsule. Depending on the calcified material produced, there are different stages wherein the lesion can be viewed, that is the radiolucent mixed lesion and the radio-opaque lesion. It can be very similar to that of fibrous dysplasia when viewing. There can be a ground glass appearance, cotton wool appearance, flocculent areas can be seen which are similar to snowflakes. There is divergence or root resorption that can be seen. Downward bowing of the inferior cortex of the mandible is a characteristic feature. Enlargement of the lesion is concentric, where it starts at a single point at the center and then it expands with hydraulic expansion, and outward growth approximately equally in all directions. So the first image A shows a part of an OPG where there is going to be an ossifying fibroma in a mixed radiolucent radiopaque stage with a mild radiolucent rimming that is seen in the anterior portion of the mandible. B is a similar opaque radiolucent mixed lesion, but a CT image of the same that is seen, causing expansion of the buccal cortex. The images below, A, B, and C at the center, showing initial lesions of ossifying fibroma where there is radiolucency that can be seen, and the D and E images are going to be the final stages where there is bone expansion. Cortex has been expanded in the occlusal image in the image D, showing flocculent cotton wool appearance. So differential diagnosis is fibrous dysplasia. So how you differentiate it is a neoplasm ossifying fibroma, whereas fibrous dysplasia is a bone disease. It has two types, the normal type, that is the adult type, and the juvenile type, whereas fibrous dysplasia is monostotic or can be polyostotic. The age is about 40 years, whereas fibrous dysplasia occurs at a very early age. So there are well-defined margins that are seen with the soft tissue capsule being evident in ossifying fibroma, whereas fibrous dysplasia they blend with the normal bone. Treatment is local excision, but recurrence can occur, whereas fibrous dysplasia has to be contoured and only after skeletal maturity is reached. The other differential diagnosis, because there are three stages in which it can develop, there is a radiolucent, mixed, and the radio-opaque stage. Cementosseous dysplasia can be a differential diagnosis, also because of the radiolucent rim being a common feature between the two. Cementoblastoma can be a common, differential diagnosis, but the thing is, the roots have been masked with the cementoblastoma appearing at the root apex. Treatment is surgical enucleation or a resection of the tumor, but recurrence is unlikely, but still can occur. The next disease is osteoma, which are benign tumors composed of mature, compact, or cancellous bone, and they are restricted only to the craniofacial skeleton. Most commonly occurs inside the frontal sinus, which is a central osteoma, and in the jaws, the premolar area or the lingual surface of the premolars is the common site. Young adults are affected. They involve the mandibular condyles at times, which are slowly progressing and shift in the patient's occlusion because it's the condyle which is affected, which is the deviation of the chin towards the unaffected side because it enlarges. The other signs and symptoms are facial swelling, pain, and mouth opening. So it is a circumscribed sclerotic mass radiographically that is seen, and large lesions mandate to condylectomy. So on the left, the B and C images are peripheral osteomas, which is osteoma cutis that can occur from the dermis of the skin also. So on the right is the osteoma that involves the bones. As you can see, on the right there is an osteoma that is seen in the frontal sinus, seen on the skull radiograph, which is the common site of occurrence for an osteoma. Gardner's syndrome is one syndrome where osteoma is a part of, along with adenomatous polyps, multiple osteomas, epidermoid cysts, desmoid tumors, impacted supernumerary teeth, and odontomas. Odontomas is one of the commonest tumors associated with the tooth. So desmoid tumors and epidermoid cysts are hematomatous lesions that are seen. So yes, adenomatous polyps, APC mutation is one of the cause for Gardner's syndrome. And on the right, you can see the OPG where there are multiple osteomas seen in Gardner's syndrome. Osteoblastoma is a tumor of the arising from the osteoblasts, which are larger than 2 cm and go up to 10 cm in size. They are similar to that of cementoblastoma, but do not obscure the roots. The primary difference is whether the lesion is fused to the tooth or not. The vertebral column, sacrum, calvarium, long bones, and small bones, and hands of the feet are common areas where an osteoblastoma can occur. In the jaws, if it occurs, mandible is the most common location. Females are more affected. Pain, tenderness, and swelling are common in osteoblastoma. Again, it has a radiolucent rim surrounding the osteoblastoma. Tooth mobility, root resorption, and displacement of the tooth can be seen. So the radiographic features are well-defined or ill-defined radiolucent lesion with patchy areas of mineralization is seen. They arise within the medullary bone and as a bony outgrowth from the periosteum also. So can be from the medullary bone or from the periosteum. They are treated by local excision or curettage. The prognosis is good. Some lesions can regress and after incomplete excision. They can recur and may undergo a transformation into an osteosarcoma. So the next one obviously is an osteosarcoma. Like the osteoblastoma, if not removed properly, can be an osteosarcoma. Osteoblastoma can be an osteosarcoma if not removed properly. So it's a rare tumor of the jaw, occurs in males twice as frequently as in females. The peak is in the fourth decade. It is a rapid enlarging swelling with pain, tenderness, erythema of the overlying mucosa, ulceration, loose teeth can be seen, nose bleeding, hemorrhage, nasal obstruction, exophthalmos, that is the eyes being popped out, trismus and blindness can be the symptoms that are seen if the osteosarcoma is seen in the head and neck region. Hypoesthesia, there is has been reported in cases with peripheral nerves have become when peripheral nerves have become involved, that is the sensation has been reduced. So the maxillar mandibular ratio is that it can be equal, that is it is more likely to occur either in the maxilla or in that of the mandible, and there's no predilection for that, but it is unusual in the jaws, more common in the long bones of aging males, that is in the males who are in the age of puberty. So osteosarcoma is associated with Lee-Fromeni syndrome, retinoblastoma, Rothman-Thompson syndrome, Werner syndrome and Bloom syndrome. These are syndromes that are associated with a number of cancers. So previous irradiation is an increased risk for the tumor to occur. Osteosarcoma secondary to Page's disease is estimated to be about 1%. So Page's disease can also transform into an osteosarcoma, but the percentage is very less. There are two forms, the central and the peripheral forms. The central types are osteoblastic subtype, consists of an osteo or immature bone. It has another subtype which is chondroblastic, showing atypical hyaline chondroid tissue. The fibroblastic subtype showing spindle-shaped neoplastic cells arranged in herringbone pattern, similar to that of fibrosarcoma. The only difference is there's going to be, in each of the type, there is going to be an osteoblast number that is going to be increased, which will be a differentiation from the chondrosarcoma or from the fibrosarcoma, wherein chondroblast is going to be increased for the chondrosarcoma and for fibrosarcoma, the fibrous tissue. The formation of tumor osteoid differentiates it from the osteosarcoma from the fibrosarcoma. So combination of radiodense and lucent lesions are seen. Cortex is invaded and eroded by the tumor, which extends into soft tissue, frequently eliciting a periosteal reaction. Sometimes the tumor grows, expands the bone without violating the cortex. In the purely lytic lesions, it cannot be differentiated from metastatic disease radiographically, because metastatic disease also, there is haphazard resorption of bone that is seen, destroying the nerves. Specifically, if it's in the mandible, the inferior alveolar nerve canal is going to be disrupted, and there is going to be haphazard destruction of bone. So, Codman's triangle is one characteristic feature of an osteosarcoma, whereas there is lifting of the periosteum in the shape of a tent. The sunburst, sun-ray appearance because of the mineralization of the Sharpie's fibers surrounding the teeth and small vessels within the adjacent soft tissues. If it involves the maxilla, the earliest sign on an IOPA is the sclerotic mass projecting beyond the height of the crestal bone. That's between the teeth. In the crestal bone, there is going to be a sclerotic mass that presents. It's the initial sign of osteosarcoma. Garrington sign is the widening of the pedial space along the one side of one or more roots, along with the loss of lamina dura, which is seen in osteosarcoma. These are the signs that are seen in osteosarcoma. So the first one is the occlusal radiograph showing sunburst appearance, which is the mineralization of Sharpie's fibers in the mandible. The one below, the occlusal radiograph, that shows the Codman's triangle, where there is lifting of the periosteum along with sunburst appearance that is seen. So one significant feature is any biopsy that you take a radiograph initially, and then you don't take a biopsy from the site of a Codman's triangle, because that's the area where you don't find any malignant cells. So the one on the right is the OPG, when you see there is a lesion that is present in the region of 33, 34, 35, 36 and 37, where there is going to be loss of there is a widened perial space with loss of lamina dura on one side of the roots of the teeth that is seen, which is characteristic for osteoblastoma. Alkaline phosphatase or lactate dehydrogenase serum levels can be increased, and surgery is the mainstay of treatment for osteosarcoma. Ewing sarcoma shows similar features to that of osteosarcoma, but it's a primary malignant tumor of the bone with undifferentiated round cells. There is also another genetic cause, that is translocation between chromosome 11 and 22. The third most common bone neoplasm after osteosarcoma and chondrosarcoma is Ewing sarcoma. It occurs in the second decade of life, with approximately 80% of the patients being younger than 20 years of age. Male predilection, all of which is similar to that of osteosarcoma. Mandible is more commonly affected. Pain with swelling is a common symptom. Fever, leukocytosis, elevated ESR is seen. It penetrates the cortex, resulting in a soft tissue mass overlying the affected area of the bone. So paresthesia and loosening of the teeth are also common features. So lytic bone destruction with ill-defined margins, similar to that of osteosarcoma or metastatic tumor. Cortical destruction or expansion may not be present, whereas in osteosarcoma there can also be bone formation and bone expansion that can be seen despite the lytic lesions that are visible or evident in osteosarcoma. So onion skin periosteal reactions are commonly observed in Ewing sarcoma, also can be seen in Gary osteomyelitis, but it's a very characteristic feature of Ewing sarcoma. Surgery, radiotherapy, chemotherapy can lead to a survival rate of 40 to 80% for the patients, but the risk for post-irradiation sarcomas can develop after radiating patients with Ewing's. So radiation is not usually recommended. It can metastasize to the lungs, liver, lymph nodes and other bones. Pelvic lesions are associated with the poorest prognosis. So this is one Ewing sarcoma seen in the oral cavity, and the characteristic onion peel appearance, where there is this occurs because there is a periosteal reaction that takes place, bone resorption that takes place. Again, there is going to be bone formation. So when there is repetitive bone resorption, formation, resorption and then formation, there is going to be an onion peel appearance, as the arrow mark here suggests, which is similar to that of the onion peel where there is resorption and bone formation. Metastatic tumor of the jaws. This may arise from primary carcinomas at any site, and usually from the breast, lung, thyroid, prostate, kidney, which give rise to the metastatic tumor of the jaws. The spread of a carcinoma to the jaws usually occurs by a hematogenous route, and older adults are more commonly affected. Jaw is an uncommon site for metastasis, but still it can occur. And when it occurs, the mandible is the most, that is posterior mandible is the most common site. Pain, swelling, loosening of teeth or a mass with paresthesia can be the features. There is involvement of, if there is an involvement of the inferior alveolar canal, there is going to be a numb chin syndrome, whereas there is paresthesia that is evident in metastatic tumor of the jaws. There is unexplained loss of sensation in the lip and the radiographic features are radiolucent areas with half-hazard borders, which shows a moth-eaten appearance. On occasion, a metastatic tumor may cause widening of the perial space and simulate new bone formation in the metastatic site, resulting in radio-opaque or mixed radiolucent radio-opaque lesions. So this is an part of an OPG showing radiolucent lesions and destruction of the inferior alveolar nerve canal at the site of the premolar and the molar, which is seen. The prognosis is poor because there is metastasis. Obviously, there is a primary tumor elsewhere that also has to be treated. So when you see if it is metastasized to the jaws being very rare, if it is still metastasized to the jaws, patient usually is at stage 4 of the tumor. Excision or radiation therapy for solitary lesions can be given to just improve the quality of life for the patient. That is, if ingestion or intubation should be possible, this can be done. And jaw involvement is always associated with widely disseminated disease. The 5-year survival rate is usually low, and they do not survive more than a year.